Okay, so good evening, everyone. My name is Sharif Fawad, consultant bariatric surgeon at EMBMI Derby and professional educational lead for BOMSS. And welcome to this evening's Journal Club. It's the 8th of February 23, and I'm delighted to have the team from Whittington step in at very, very short notice with 2 days' notice because our planned team who is meant to deliver this month has had to pull out at the last minute. So thank you ever so much to Chetan, to Oscar, to Katrina. With 2 days' notice, they've agreed to pull a couple of papers, thankfully presented from their, published by their unit, actually. So this will be a first for our journal club to have the authors present and share their papers with us. Notification of the next educational session will be on the last Wednesday of the month, the 22nd of February, and that's the educational webinar. Will be Professor Alex Miras talking about PCOS and bariatric surgery, so we really look forward to that. As always, these sessions are recorded, so we will send out a recording to those who couldn't attend, and if I can ask you to please post your Q's and A's and any comments or questions via the Q&A button. And we'll answer those during the Q&A. Okay, over to you, Chetan. Thank you again for hosting tonight. And if you'd like to introduce your first speaker.
Thank you very much. Thank you, Sharif, for this kind invitation. And thank you on my behalf to Oscar and Katrina as well for stepping in a short notice. No time wasting. First of all, I would like to introduce Oscar, who is a foundation doctor in Nottingham. He did his medical school from Malaysia and came over, and he wants to be a surgeon. And he's actually the first author of this paper and led the paper writing, I would say. So without any delay, Oscar Wong is going to talk about facial changes after bariatric surgery, which is actually not very widely talked topic. So over to you, Oscar.
Hi, I'm Oscar. I'm a F1 doctor currently in Nottingham. I've just finished my general surgery posting, currently doing respiratory, and I'm really happy that Mr. Palmer has invited me to present our paper, which was published not long ago, I believe in November or December last year. So the topic that we're going to be discussing today is the changes of facial feature after bariatric surgery, a systematic review. And as you guys can see, that's the list of authors, including Mr. Palmer. Really lovely team to work with. Okay, so without further ado, let's crack on. So as we all know, obesity has become a really major public health problem. It's affecting around 750 million of people since the last data was in 2016. And the rise in the prevalence of bariatric surgery mirrors the obesity pandemic. So, but however, the current analysis is actually restricted to changes in body composition after bariatric surgery. The effect of massive weight loss after bariatric surgery, however, is not limited to only limbs and trunks, but it also affects the face, especially facial structure. But however, it's not really well investigated. So the aim of our review is basically just to try to summarize if there's any changes in facial structure post-bariatric surgery from the existing literature. Okay, so we have done this systematic review. First of all, we started with a systematic literature search that performed in multiple electronic databases until February 2022. So basically, we have two authors independently screening through the articles, through their title, abstract, and full text. And we were looking for studies that addressing changes in patients' facial feature post-bariatric surgery, irrespective of differences in the measuring outcomes, even though it was quite heterogeneous, because as Mr. Palmer mentioned at the start, it's not really well studied yet. So we were just trying to include everything we can find from the literature. So we also have done some risk of bias assessment using the Newcastle-Ottawa scale. And overall, all the 4 papers included were deemed good quality. Okay, so this is just like a summary of the result. So we have included 4 cohort studies involving 129 patients from 3 countries in the span of 2011 to 2020. From the span of 2011 to 2020. And this is just a slide from our paper. So 4 articles were included, 3 countries, as I mentioned, Brazil, USA, and Germany. So we managed to identify 2 major themes that people were assessing after bariatric surgery regarding facial structure changes. So outcome number 1 was perceived age, and outcome number 2, anatomical changes, which I will elaborate in the coming slides. Okay, so first of all, 2 studies. As I mentioned, there were 4 studies in total, and then 2 studies were trying to investigate the perceived age, and 2 studies were trying to investigate the anatomical changes. Okay, so I'll be talking about the perceived age first. So as a paper by Whittington and the team, so they were trying to assess if there's any changes in terms of perceived age 1 year after bariatric surgery, and the assessment was done by plastic surgeon. And they actually found that the patient was significantly older by 21.1 months on average after this 1 year after the surgery. And they have managed to identify a few factors that can actually promote aging on their aging effect on patient's face after the surgery, including if it's male in gender, if it's older than 40 years old, if they have a preoperative body mass index of 40 to 49.9, or if they have a preoperative body weight exceeding 127.65 kg, or if the percentage of their excessive weight loss was more than 75.13%. So they managed to identify that if you have the following mentioned risk factor, it can actually enhance the effect of aging, of massive weight loss, particularly after bariatric surgery. Okay. So the next paper, Papon Ian. So what this team has done differently, so they assess the perceived age 3 to 6 months after bariatric surgery, and they gather the photos of the patient before and after. They use some software to try to randomize the photos, and then they put it into online surveys. So people will have to rate the attractiveness as well as the perceived age of the patients. And this was done by a general public as compared to the previous study was done by a plastic surgeon. So overall, patients were found to be significantly more attractive post-surgery. But then, however, they do have 2 interesting findings, where first, mild weight loss is perceived to be younger but less attractive, where substantial weight loss is perceived to be older but more attractive. Okay, so these 2 papers basically has been on a message that by undergoing bariatric surgery, it will induce massive weight loss, and it kind of has an aging effect on the patients after bariatric surgery. Okay. So I understand this study is this field is not really well investigated. You guys might not hear about it much. If you have any question, do pop it in the chat box, and we can probably talk about it after the presentation. Okay. So now we're moving on to the second part of my paper. Basically, what we talk about anatomical changes. And there are a few things before I talk about it. I just want to make sure people are familiar with the facial landmark. Okay, so this is actually a figure that I took from our paper. So as you can see, there are a few points that I have sort of circled. Please just ignore the color for now. It will be quite useful in the next section, in the next slide. So as we can see, a few landmarks let me start with tragus. Corner of the eye, exocanthon. Nasion, which is the nose bridge. Pronasal, subnasal, so upper part and then lower part. Sternum, which is the midpoint of your lips when your mouth is closed. Pogonion, which is the most protruding point of your anterior chin. Menton, which is the lower point of your chin. Okay, so I understand this might be new information. Don't worry, we'll try to revisit the picture after the next slide if there's any confusion. But just remember where these facial landmarks are located. Okay, so interestingly, this is the first paper out of the two papers that assessed the anatomical changes after bariatric surgery by Peters and his team. So they actually did a 3D imaging in 23 patients 1 week before and 6 months after the bariatric surgery. So what they actually found was the distance between, so they used tragus as the landmark. So the distance between tragus and the corner of the eye, subnasal, which is the lower part of your nostril, and the tragus and sternum, which is the middle part of your lips, was significantly increased. So the distance actually become longer. But in contrast, the distance between tragus and pogonion, which is the chin, menton, which is the lower part of your chin, tip of your nose and your nose bridge was significantly decreased after the surgery. So we will talk about why in the coming slides, but then we can conclude that there is some significant cranial facial changes after the bariatric surgery, and this was not known to many people, including the surgeon doing the surgery or the patient who are undergoing the surgery. Okay, and they have also do a heat map scan, and they also realize that there's some sagging of the face of the skin, facial skin, due to gravity after the surgery, due to the lost weight, which I will show. Yeah, so this is also a picture taken from the article. So they can actually show that there is some facial skin sagging, which is not much addressed or even talk about after bariatric surgery. Okay, I hope everyone is doing fine so far. I'm really sorry for the overwhelming information. Okay, so let's move on and talk about the last paper that we have included. So this last paper also talking about anatomical changes, which is by Santos and his team. So what did they do is they did a radiographic examination. So they try to measure the changes of the face using X-ray and a few landmarks. So what did they find? So they find that there is a significant reduction in the in the neck circumference, where there's an increase recorded in both the interlabial, which is between your lips distance, and also the height of your right nostril. Clinically, they found that there's a significant reduction in the nasal obstruction symptom evaluation. So the patient, the nasal obstruction they had before bariatric surgery has become much better. And they also found smaller angle between the cranium and the cervical spine, smaller velopharyngeal space, which is from the posterior pharyngeal wall, or from your heart palate all the way down to your posterior pharyngeal wall. Higher bone about the mental point, and reduced distance from higher bone to the mandibular plane. Okay, so all these changes that were present in the patient before bariatric surgery, they have actually become smaller, so becoming more and more closer to a normal person, which is within a normal range of their weight and BMI. They also noticed the shift from the class 3 and class 4 of the OSA scale to class 1 and class 2 after bariatric surgery. So all these are suggesting that their airway function is getting better. Okay, so you might ask, so why, how is all this important? So I believe our paper talk about three main questions. So does losing weight affect aging and aesthetic outcome will be the first one. So as I was trying to summarize just now, we believe that losing weight, especially massive weight, does affect and has a aging effect on the face. In terms of aesthetic outcome, we do agree that by losing weight through bariatric surgery, the aesthetic outcome is improved. But however, our team do recognize the limitation, which we will be talking in a sec. But then aging and aesthetic outcome are quite subjective. And the current paper remains, they have quite small sample size. There are not many studies. So I believe we can't make a conclusive answer yet. But why is this happening? And this can be explained by the facial fat redistribution, meaning that in a certain part of your face, there's more fat than the other area. And through bariatric surgery, there is reduction of the fat pad in your face. So that's why certain area has more changes than the others. And we believe this information will be quite helpful to our patients. They should have the right to learn what is going to change it to their what changes are going to happen to their face. Okay, and moving on to the second question, how does it affect craniofacial structure and if it affects patients? Of course, as we can see from the two papers that talk about the craniofacial changes, we can see that there is facial sagging present after bariatric surgery. But however, we do agree that it wasn't discussed much, and to our knowledge, there is no clinical consensus on how to deal with it. And we would like to propose, the most likely solution would be facial rejuvenation. Can be quite effective, but it hasn't been studied much as well. And the last question, does it improve airway? And I believe this resonates with a lot of studies published. Losing weight do improve your airway function, and we are demonstrating it through the anatomical changes. So lastly, I just want to talk about the limitation. So as I mentioned, the first limitation will be the outcome we are trying to assess here are rather subjective. And due to the limited number of papers, I believe further studies are pretty much needed to make a more conclusive answer. And lastly, the last limitation is we would like to, we realize there isn't much patient-reported outcome that was assessed. Therefore, in the conclusion part, as we can see, overall bariatric surgery will promote massive weight loss, but however, it's associated with facial aging. There is a proportional relationship between BMI and facial aging and attractiveness. Undergoing bariatric surgery will result in facial skin sagging, and it will improve your airway function. But however, the current evidence remains inconclusive, and further studies are needed. A bigger sample size, longer follow-up, and multi-ethnic subjects are needed. As mentioned, the country involved are predominantly Caucasian. So therefore, we believe further studies are needed, and the current evidence is inconclusive at the moment. So our team is also preparing for multi-center studies, and we are in the process of preparing it, and hopefully it will be published and seen by you guys soon. So thank you very much for listening to my presentation. Feel free to check out our article, which was published in the Journal of Obesity Surgery. And thank you, Mr. Palmer, for inviting me for the presentation. Thank you very much.
Oscar, well done. Fantastic paper. I really, really love the topic. Really interesting. I haven't come across this area before. It's never sort of occurred to me. Just wondering from the authors, because it's very rare that we have the authors present their paper, what gave you the idea to do this paper? Was it patients coming to clinic saying, we've lost a lot of weight, we look older, I don't like how I look. What can I do about it? Or what was it?
This was a conversation between me and the senior author, Mr. Powell. So I believe this was one of the things that he looked into in his PhD study, and we both agree that this topic wasn't much investigated. So we decided it was quite interesting to look into it.
Brilliant, very, very well done. Now you've gone through 4 papers, and they're all very interesting, and they have a different slant. So I'll have to put my hand up. I haven't read your systematic review yet, only because thanks for putting it on the chat function, Matt. So I'll certainly be taking a closer look at it. Did from your review then of the 4 papers that were published, is there a level of weight loss at which patients will look younger versus look older? What sort of excess weight loss are you looking at? I know you've highlighted the risk factors of male BMI between 40 and 50, etc., to make you look older, but what level of weight loss would make you look younger versus older, if you understand the question?
Yeah, it's in that first paper, Oscar, the one before the slide. Yeah.
Oh, this one.
55% excess weight loss.
Yeah, so did the authors identify a level of weight loss that leads to sort of assessment that the patients are more attractive, or what?
Attractive. I believe that you are talking about
or aging. Sorry,
aging. Is it okay?
Yeah, aging. I beg your pardon. Aging.
Yeah. So according to their analysis, if you have an excessive weight loss of more than 75%, it can make you look older faster compared to other people who had undergone bariatric surgery. So the effect is the same for everyone, unless you are losing an excessive weight loss of more than 75%, if you get what I mean.
Okay.
Yeah, so it's sort of like a risk factor.
Yeah.
And in this paper,
also, sorry to interrupt. It also showed they made only in this paper there was a calculation that it makes you look older 21 months. So I think they did that kind of analysis as well.
Just how I mean, obviously plastic surgeons are very good at their job, but how you can judge a difference in aging by
so I think
months?
they had answered, or they had guessed, so they were told to guess the age of the patient.
Yeah,
okay.
exactly.
And that's how they then actual age and guessing age.
Yes.
Okay, so that's aging. And in terms of attractiveness, then, in terms of the differences, so they were very interesting differences. So losing weight and becoming more attractive versus losing even more weight. No, less weight loss, but less attractive, more weight loss, but more attractive, I think it was.
Yeah, very interesting. So they asked the public to sort of rate the patients on a scale from 1 to 10, if I'm not mistaken, on top of my mind. So that was the result. Actually, losing a lot of weight will make you more attractive, but just losing a little bit of weight, it actually makes you less attractive. So it's a very interesting finding, and they couldn't find out why. But I guess it's quite a motivating factor for us to try to pursue more weight loss then.
Definitely, and this is good work for your future career in plastics, Oscar. So definitely keep up the research in this area. Roxana, do you have any questions? Did you manage to catch much of the presentation?
I did. Thank you very much. We've got a couple of questions from the audience, actually. I was just going to say, so Pastor Cora's asked, everyone thinks this is very interesting, Oscar. She said it's also interesting to see what the patient's own perceived attractiveness would be, because this would likely have an impact on their own self-confidence and well-being, rather than external opinion as being thought. And I think Muwafaq Telfaz asked something similar, is that do you think having the body self-image by the patient is probably a more objective or more useful measure? What do you think?
Yeah, thank you very much for the questions. I do agree. Patient-reported outcome are quite important and has becoming more and more important over the years. So this is one of the questions that we will try to address in our coming studies that we are preparing, our multi-center studies, to assess the patient's own perceived age, perceived attractiveness, and also quality of life. And we believe that can really bring us to the question if, does this help patient in the long run, and how can we help the patient better?
And so on the data that you have at the minute available from your systematic review, hopefully last question, do you think we should be counselling and consenting patients and mentioning to them about these changes following weight loss surgery? That you're likely to look older, if you achieve the 75% excess weight loss, you're likely to look older, you may become more or less attractive. Should we be telling them that?
Certainly, I agree that we should share this information with the patient, but I believe we also need to remind them to take it with a grain of salt because the current evidence is not very conclusive. It's just one study, sample size is not big. So as much as I believe, getting the patient involved, telling them the available evidence, but we also need to, educate them how to know what is important evidence and what is, just for reference.
Okay, fantastic presentation. Really, really interesting topic, and hopefully lots more work from a PROMS point of view will follow on from your unit, Chetan, on this. Would you like to introduce Katrina? Can you stop screen share, Oscar?
Yeah, thank you so much.
Thank you very much. And while he's, I think somebody put a nice comment there, Sharif, an answer to your question that if it doesn't hamper your iPhone facial recognition, that weight loss is fine and facial asymmetry is fine. Okay, thanks, Oscar. And I would like to welcome our key member of the Whittington bariatric team here, Katrina Burton. She's a superstar dietitian in our team, and she's going to present, well, I'll let her talk. Thanks. Over to you, Katrina.
Thank you so much, Mr. Palmer. I'll remind you, you said that. So thank you so much for giving me the opportunity, albeit short notice, to tell you about our case report that just is hot off the presses. So, oopsie. Okay, so as far as we know, this is our first globally reported case report of bariatric surgery in patients who have some amount of blindness, significant visual impairments. And these are just our lessons we learned and recommendations. It appeared in obesity surgery. So as we know, diabetic retinopathy is the leading cause of adult onset blindness. It's growing in rate. It is expected to reach 191 million adults worldwide by the year of 2030. Now, as we are performing more bariatric surgeries and as diabetic retinopathy is increasing, we expect that we are likely to see greater number of patients with visual impairments who would like to undergo bariatric surgery. So to our knowledge, there was no other case reports with these two intersections of blindness or visual impairment and bariatric surgery. So what we wanted to do is just share our learning on the journey of two patients that have recently gone through our pathway. And actually one of them is still on the pathway. So the first patient is a young chap. He was 30 years old when he first came to us. He had a bariatric surgery in 2019. He had a sleeve gastrectomy. In addition to his congenital glaucoma, unfortunately, he had a number of psychiatric conditions as well. Initially, on referral, he was 206.5 kilos. And by the time he underwent surgery, he actually managed to lose about 10 kilos, that 5% of excess body weight loss, which is great, or of his weight loss. Now, at 3 months and 6 months, he was doing really, really well. As you can see, he's lost about 46 kilos. Unfortunately, as you see, his surgery date was 2019, and therefore he was undergoing his recovery after bariatric surgery, those crucial 2 years, in lockdown. And as you see, it reflected in his weight. Patient reported losing momentum as he was self-isolating, and he was actually self-isolating longer than most people. He felt uncomfortable leaving his house until he was fully vaccinated. So his appointments became telephonic. he started comfort eating and reintroducing fast food. You know, unfortunately, a worldwide pandemic is not something that happens a lot, and patients and many of us didn't know how to cope with that world, and sometimes it resulted in people turning to comforts that they've known before. So unfortunately, he has regained a significant amount of that weight. However, when we saw him at 24 months, 2 years post-op in clinic, that was the first time he actually came face to face. He was actually still very glad he had surgery. He managed to maintain some of his weight loss. We did discuss further dietetic input, the possibility of revision surgery, but he was currently not interested in undergoing any other treatment. So our second patient is a young lady of 43 years old, also had a sleeve gastrectomy. Now she's still on our pathway and she is registered partially blind. She is 100% blind in one of her eyes, but in her second eye, she has a tiny bit of residual vision. And so she actually, and we'll talk about sort of patient preferences in terms of how they receive information. She does prefer to read her own letters and education material. So she came to us at a fairly low weight with a BMI of 35 and smidgen. Now, 3 months post-operatively, she was struggling a little bit despite meticulously following guidance, but she was brilliantly proactive. Anytime something didn't feel right, she would contact us, she would ask for advice. And by the time I saw her in clinic at 6 months, she was doing really, really well. She came in a new outfit and she was on the top of the world, and she continues to do well. So at the time of writing this report, she was 6 months post-op, but actually she's progressed since then, and she continues to do really, really well. And she's so happy she had surgery. So then why did we do this case report? Actually, we used it as a learning tool for ourselves to gain better understanding of the individual needs our patients have, but also to improve our knowledge and access for bariatric surgery. To learn about preferred communication ways our patients have. So, you know, just because somebody is blind or visually impaired, that doesn't mean that they know how to use Braille or that they would prefer to do that. Nowadays, we have a lot of electronic options. And some patients, as my lovely lady, she prefers to get her letters and use a loop to help her read. We also wanted to gauge patients' interest in how we can help them make lifelong changes, dietary changes, how we can support them with meal preparations or medications, who we can co-opt from their family and environment and to help them with their progress, how to help them navigate logistics of everyday living and coming to their appointments. So we came up with these few options, and I'm sure there are other things we haven't thought about. So if you thought about something or there's something that you have experience with, we'd love to hear about it. But we think pre-operatively, robust education in whatever method the patient finds it suitable is an absolute must. So for some people, it's going to be attending groups and one-to-one sessions. For some of them, it's going to be, you know, receiving. So we have an audio-visual education session, so sending that to the patient so they can listen to it. Involving family and carers and whoever else may be involved in the patient's life, asking what method of education they prefer. Is it Braille? Is it electronic letters? For example, I've learned that all of our websites are enabled, audiovisually enabled, so patients can listen to our websites and so on. We also thought about it would be really useful to use maybe a 3D model. So we have those 3D models of stomachs for our band patients, and those could be actually fairly useful for patients with visual impairment, so they can touch that stomach and see what will become to them after the operation. And also just discuss the choice of safe bariatric procedures. So in the perioperative period, we thought it would be very important to have one-to-one nursing for our patients, just because they are in an unknown environment. So they may be very skillful at navigating their own homes and lives, but maybe if you're in an unknown noisy environment like a hospital, it may be more useful to have a one-to-one nurse. Also, a more liberal access to family members, so either over the phone post-operatively or even just allowing them to come to the bedside and help with the post-operative education on the ward. And I also learned that we have guides in the hospital who will help to navigate the patient's appointment. So as I said, this was a great learning opportunity for our team to know what we have available to offer our patients. Now, post-operatively, extending the opportunity of face-to-face appointments, offering a greater number of appointments, as well as actually extending that usual 2-year follow-up, especially since, and this was something I learned, as dietitians, unless it's related to food, we have sort of very skewed learning. And so I learned that after bariatric surgery, in the early post-operative period, patients who already have sight-threatening diabetic retinopathy, they can actually experience a worsening of their eyesight. And so extra vigilance with these patients, maybe seeing them more often post-operatively, and even just patients with regular eyesight impairments or our regular patients, and whenever we're concerned that there may be signs of a vitamin A deficiency, monitoring for that, and obviously correcting where needed. So in conclusion, we feel bariatric surgery is a safe option in patients living with visual impairments or blindness. Patients should be closely monitored by an MDT. Excellent patient communication is a must. And obviously, we need to offer ongoing support for those optimal outcomes. But we are strong believers in offering equal access to bariatric surgery to all patients, because we know that it has such life-prolonging and quality of life improving benefits. And even though these patients may need extra appointments, they should be able to access our services. And that's my story. So if you have any questions.
Thank you, Katrina. And again, really, really interesting paper from your team. Can you just stop the screen share for a moment?
Yes, absolutely.
So thinking outside the box and looking at an area that again, we don't consider in our everyday practice. It must be a really scary experience for patients with blindness in theatre when you're operating on them. So did you have to make sure that sort of the staff and the normal sort of background noise in the operating room and the anaesthetic room, that everybody's quiet, so that the anaesthetist or you can communicate with the patient and let them know what's going on? It must be a terrifying experience going into a theatre when you're unable to see.
Mr. Palmer, I think that's for you.
Yeah, no, yes. I think it was making everyone aware. And what is impressive, Sharif, is exactly correct, and how supportive and the NHS team is. And I think that's what we normally don't talk of. But as soon as people realize that there are some challenges here, everyone went out of their way to make the patient comfortable. And as you can see, the first patient, even though he didn't lose that much weight and weight regain, he's still so pleased that he went through this whole journey. But yeah, I think everyone was adapted to the whole thing along with the patient. But I assume obviously had more challenges than us.
And the one-to-one mobilization, one-to-one nursing care for the early mobilization and to help them get out of bed hourly and so on, with the enhanced recovery. So it is labor intensive, but it's definitely something that we need to think about so we can serve the needs of different patients that are out there. What about patients who are profoundly deaf and completely lost their hearing? Do you have any experience of bariatric surgery in those?
I don't.
No.
Okay. Yeah, so
we have 2 more blind patients, I can say, with blind in our pathway now.
Okay.
Yeah.
Okay, very good. Well, looks like you're going to have a nice series to publish and update this case report on. So I've operated on 2 completely deaf patients, and the initial consultations were via Zoom, and obviously you have to allow an extra long consultation time so that they can lip read you. Okay. But that worked absolutely fine. This was before COVID, I have to say. Now with wearing masks, you know, you have to think how you're going to be able to communicate with patients like that. But just interesting, in our trust, they've introduced the masks with the clear area around the mouth. I don't know whether you've got them in Whittington. They're hopefully will be made more available in the NHS, so that patients can at least lip read with you wearing your mask on. Our trust, because of an increase in COVID and so on, we're back to wearing masks in all clinical areas, unfortunately. Roxana, any questions or any questions from the audience?
Yes, thank you. I was just wondering, in terms of the ophthalmology follow-up and preparation and stuff, do the ophthalmologists get involved? Because obviously, as Kat, you said, there's dietetics, you know, dietitian review and vitamins, especially vitamin A, is a really key part. But what about the ophthalmologists? Do they have to see them before and after?
You know, that's a brilliant question. And to date, at least from my literature review and from the papers I read for this purpose, there's just no current evidence-based guidelines on ophthalmological screening before or after surgery. And so maybe there is a piece of work for someone to do to look at pathways for patients wishing to undergo bariatric surgery. And so maybe that's something that we can look into, or at next BOMSS invite an ophthalmologist.
Yes, so there are some recommendations out there. So I've given a previous talk to the British Retinopathy Society, and normally patients with retinopathy will be in a screening program and they will have regular retinopathy checks. But the key thing, if you are operating on a patient who you know has retinopathy, is to ask the patient to let the retinopathy screening team know, and they should arrange for a retina check 3 months after bariatric surgery, because that's the crucial that's the crucial period of the improvement in HbA1c and glycation and so on. That's a sight risk, and so that if there's anything that will happen, it will happen in those 3 months. But it's a learning.
You are correct, Sharif, I think, and that was a new learning for me as well, because you just assume things will always get better, but here is that window where things can actually deteriorate. But that's for the diabetic retinopathic, whereas our patient had congenital glaucoma leading to that, and the other patient had already blindness, so that thing didn't affect these 2 patients. But yes, diabetic retinopathy patients, that has to be arranged. You're correct.
Yeah, and the same with pregnancy as well. The sight can worsen with pregnancy, so it's a similar thing. Just had a question. So how often do you need to check vitamin A levels in patients who had bypass surgery?
Usually unless they had a DS, we wouldn't routinely check vitamin A. However, if they showed some overt sign of, or if they explained that they have night blindness suddenly, or something that would make us believe that they may have developed vitamin A deficiency, then absolutely we would probably order vitamin A. Yeah. I think with the diabetic retinopathy, it's also worth having that chat pre-op with patients, because very often maybe they've heard all life long, because of your poor sugar control, your eyesight is worsening. And actually, if they go in with an expectation that it's going to get better, but in fact, it can get worse. So it's also probably worth managing patient expectations.
Very good. And just one final question. Do you have then Braille? Do you have information sheets available in Braille in your trust?
We can make them available, yeah.
For specific patients?
Yes.
Right, fantastic. Well, that's really, and is that just in your trust, or do you think that's available in all trusts? I've never had to ask for this to happen. It is, I think by law, that trusts would have to provide information sheets in that way, the same as translated in other languages and so on. So it might be worth people exploring that with their trust before the need arises. Okay, Team Whittington, thank you ever so much again for stepping in with 2 days' notice to help us with tonight's journal club. You've all been absolutely fantastic, and the papers are really, really good choices. So thank you so much once again. Next session, 22nd of February, Alex Meares, PCOS and bariatric surgery. We've reached the end of tonight. So thank you all very much. And Roxana, thanks very much for joining also.
No, thank you very much, everybody. Thank you, Whittington. That was really interesting.
Have a lovely evening. Thanks, Chetan.
Thank you. Bye-bye. Have a nice evening. Bye.